Welcome, everybody. My name is Tracy Milligan, and I'm the Vice Chair for Education in the Department of Neurology at Brigham and Women's Hospital and Harvard Medical School. And I am dedicated to providing neurologic education and want to welcome you all to our session today. This session was inspired by some of the cases that I've posted in the hashtag Neurology Morning Report on Twitter. Dr. Ropper has been advising on some of those cases and has agreed to speak to you all today about Guillain Barre syndrome. Now I'd like to introduce Dr. Allan Ropper. And I know this introduction won't do him justice, but I'm going to start out by saying that he has been one of my most important teachers of neurology, and that I, like probably many of you, have learned so much from him by what he's taught and by the example that he has led. He is a world-recognized leader in neurology and has been practicing clinical neurology for decades. He is the Executive Vice Chair of the Department of Neurology at Brigham and Women's Hospital and the Deputy Editor of the New England Journal of Medicine. He is editor of the most widely used textbook in neurology, Principles of Neurology, and has authored many books. His most recent books, Reaching Down the Rabbit Hole and How the Brain Lost His Mind. I highly recommend that you all read those. He is also published his a volume of his neurological CPCs from the New England Journal of Medicine, along with Dr. Marty Samuels, and has authored a textbook on Guillain Barre syndrome. He has been writing about Guillain Barre syndrome for at least 40 years. He's one of the founders of the field of neurocritical care neurology and has a deep expertise in this field. So thank you very much, Dr. Ropper. I'll turn it over to you.
Thank you. That's very, very kind of you. Thanks, everyone, for joining us. Really appreciate it. I see people I recognize. Mike, hi. Said hi to Farzaneh. There are others out there. It's very nice of you to join. First and foremost, I hope everyone is well and safe in these surreal times. But I think that by coming together as neurologists in particular, it provides a little bit of a sort of a structure for meaning that should help us through while this whole thing settles down with the virus and social unrest and so on. Anyway, let's put that behind us for a minute. So, as Tracy mentioned, I'm actually an accidental Guillain Barre expert. The origin story is that in 1979, I recognize some of you on this Zoom call were not born then. There was a floor set aside at the Massachusetts General Hospital for people who were post-operative from neurosurgical procedures or who had status epilepticus or bad myasthenia. And it was sort of called the Neurology Special Care Unit. And I was rooting around for a job at the time. I actually was I had signed a contract to go into private practice on the South Shore. And the new chief of neurology, Joe Martin, said, you know, I'd like with neurosurgery to set up a neurological intensive care unit. Would you hang around and try to make that work? So I did a medical residency at the University of California, San Francisco in a very activist role, very acute, a lot of ODs, intubating people left and right, put in 200 Swan-Ganz catheters myself as a resident, something that's not even allowed now. So I jumped at the opportunity, and with a man named Sean Kennedy, an anesthesiologist, we built this unit. At the same time, the people at Hopkins, residents at Hopkins, neurology residents, picked up on a letter in the Lancet from Hammersmith Hospital written by a pulmonologist who treated a handful of people with Guillain Barre syndrome with plasma exchange on a lark. Now, it was a day before informed consent and protocols, but they got better very quickly in a way that suggested it might be effective. So these residents, and I was a year out of residency, put together a clinical trial that became the North American Guillain Barre plasma exchange trial. And we had access to plasma exchange through the blood bank, through some very, very cooperative blood bank people. That resulted in the referral to this unit of close to 400 patients with Guillain Barre from the Northeast over a period of several years. So I was just standing there and watching the velocity of these cases and just trying to make a record of what was going on, and it resulted in a monograph and a lot of what I know about Guillain Barre. And then you're caught up in a field and you really can't escape it. It turned out to be utterly fascinating historically and so on. So first of all, the proper pronunciation for everybody, no one in particular, is Guillain Barre. And the reason I know that is that Guillain's grandson, great-grandson, is alive and lives in Vermont. And I've spoken to him and visited him. So it's Guillain Barre. And of course, the original article is Guillain Barre and Stroll. Now, the S is for syndrome, but originally it was for Stroll. And the reason Stroll got left off, just for your information, is that he was from the Alsatian region of France, which is abutted Germany and was always viewed with suspicion by the French. So in all the subsequent articles, Guillain and Barre left his name off. And ultimately, of course, Guillain, in a megalomaniacal move, called it his disease and tried to get rid of Barre. Barre's an interesting character. Barre's contribution in the original and subsequent articles was that he was one of the first electrophysiologists in Europe. He made smoke drums, where he took glass drums that were specially made and he smoked them over a fire and put a needle on them and then had somebody turn them at a constant speed, and he connected the other end to electrodes. And he did the first nerve conductions and EMGs ever done on the European continent. He became the first person to head a rehabilitation foundation and then a hospital. He founded the field of neurological rehabilitation. So it's historically very interesting. It's a disorder that was described first in 1857 by, as you know, somebody well before him. Landry was a wealthy landowner, and he noticed that after an influenza epidemic, a lot of his the workers on the farm, they were no longer serfs, they were sort of like sharecroppers, were getting sick with a paralytic disease and died and couldn't breathe. And he wrote this up very extensively in incredible detail. What Guillain Barre and Stroll did was a single thing, and that is to add a test. Just like in modern medicine, if you can find a laboratory test that marks a disorder, you become famous. All they did was realize that Quincke in Germany had started to analyze spinal fluid, introduced the spinal needle, and that the protein in these cases was high, whereas in poliomyelitis, which hadn't yet been named but was known as infantile paralysis at that time, was a febrile illness where there were cells and here there were no cells. And all of a sudden they became famous. It's like discovering CRP or any other marker. But they denied that what they were seeing clinically was the same as what Landry had seen, because his patients died and most of theirs did not, which is ridiculous. Anyway, so if we take GBS to mean Guillain Barre syndrome, the S for syndrome and not Stroll, what do we mean? Well, it's a real problem. I think everybody knows what the typical instance looks like. It's, a subacute to acute quadriparetic areflexic predominantly motor disorder with paresthesias distally. That would be the archetype. The problem is that the dimensions of that are pretty wide when you start to look. So what about cranial neuropathies? What about pain at the onset? What about a pure sensory variant? What about Fissure Syndrome? What about pure pan dysautonomia? Are those variants or parts of Guillain Barre? Well, it depends then on what you think the pathobiology is. And that's complicated. So we recognize the central core syndrome. What's useful about that, though, is that we recognize what it's not. So, for example, somebody gets an infection and then they get brachial neuritis. That's not Guillain-Barre syndrome. And the reason is several-fold. The first is, by and large, Guillain-Barre syndrome, after a day or two, requires bilaterality and relative symmetry. That's number one. Number two, there are very, very, very few cases that eventually do not acquire areflexia, or at least hyporeflexia. There were some early cases that were said to be hyperreflexic, but the description is not persuasive that they're Guillain-Barre. What about the case that Dr. Milligan presented a few weeks ago, which ultimately resulted in giving this talk? Somebody presented with a Bell's palsy. Well, I got to tell you that all the cases of Bell's palsy I've been shown at the onset of Guillain-Barre to disprove the fact that everything should be at least bilateral, if not symmetric, have turned out not to have unilateral facial paralysis. It's just very asymmetric, and after days or a week, it becomes bilateral. There are special cases, particularly HIV and Lyme, which I'll mention in a minute because it has an uncertain relationship to GBS, which can start with a true Bell's palsy, but it is, and then progresses, or let's say to which is added a Guillain-Barre syndrome. But I don't think the Bell's palsy itself is part of Guillain-Barre syndrome. None of these things, of course, are never. They're just pretty close to never. So there are edges to the Guillain-Barre syndrome. Clinically, what would you accept? What would you not accept? Things like Fissure syndrome really push the envelope because they make you say, well, we're not exactly sure what the pathology of Fissure syndrome is. I have some information on that. But it is merged with or related to Guillain-Barre because it's acute and subacute. It has crossover syndromes, and that's the essential element in including things in the larger package of Guillain-Barre, that you've got typical Guillain-Barre that either include features of these variant syndromes or start with the variant syndrome and don't remain pure. That is, they go on to become generalized, symmetric, motor predominant, areflexic paralysis. Syndromes that begin with paresthesias distally are usually aligned with Guillain-Barre if they're not MS. The reason I say that is that the archetype for Guillain-Barre, of course, is the inflammatory demyelinating form. I'm going to show you the path in a minute. And the demyelination is what causes the positive phenomenon of paresthesias. If you query people with Guillain-Barre early on, and it's a good question to ask them, are you numb? They come in saying, I'm numb, something's wrong. If you press on them, they're not numb. They have a positive phenomenon, not a negative phenomenon. The paresthesias, we think, based on the research of Gunnar Wallen in Sweden, the microneurographer, is that as the myelin withdraws from the node of Ranvier, it exposes the axon and sodium channels that are normally covered by myelin and are not susceptible to being depolarized. And all of a sudden, two things happen. This is Gunnar Wallen's contribution. The first is that the area that's denuded, withdrawn, the myelin sheaths coming away from the node, begins to become active spontaneously. So you get spontaneous sensory symptoms, mainly in the largest fibers. That's paresthesias. The other thing that's very interesting and unexplained is that demyelination, segmental demyelination, destabilizes the entire axonal membrane up and down the nerve across its entire length. So it's not only that it's spontaneous, it's also ectopic. That is, you can find other sites way away, distant from the demyelinated area, that begin to become active and are depolarized spontaneously. So if you have a syndrome that crosses over into Guillain-Barre symptomatically, either by merging into it or by containing or starting pure, and that's where Fissure syndrome comes in, and then becomes typical Guillain-Barre, I think it's fine to call it a Guillain-Barre variant. There are oculopharyngeal variants. They're rare, that look like myasthenia, but they have paresthesias, and they have areflexia, or dropped reflexes in the arms, and so on and so forth. Now, the other thing that ties Guillain-Barre together are the tests. I'll make a couple of comments about that. First is that if you have a demyelinating neuropathy in nerve conduction studies and showing little, if any, early axonal damage, that is lack of spontaneous activity on the needle exam, you're looking at a demyelinating condition by and large. Most of those are inflammatory. Some are immune and non-inflammatory. But that's the core feature of Guillain-Barre, is the electrophysiology. So the thing about Fissure syndrome is if you dig deep enough, you find that their sensory potentials are down, and eventually you get a little bit of conduction block in a lot of cases, even if they're not weak. That's what makes it an acute to subacute demyelinating polyneuropathy, which might be a better definition for Guillain-Barre syndrome, AIDP, with or without the I for inflammation. The other thing, of course, is the one that started the whole name. It's the business of high CSF protein with few cells. Let me go to the end of that story. I have to say that we do LPs all the time on these patients, and it's pretty much a waste of time. You can have Guillain-Barre with fairly normal CSF protein early on, for sure. Probably 15 to 20% of cases in the first 5 days, if you do systematic taps, will have normal or near normal protein, under 45 milligrams per deciliter. Why do we do it? I don't know. I think we're insecure, and we think it's part of the syndrome because it's historically bound. If there were no other test, yeah, it would be useful. Now, before leaving that, I will say that if you do an LP, I know you're surprised that the protein may or may not be elevated, but there are 30 to 100 cells. That's useful to know, but in a sort of backwards way. It doesn't make the diagnosis of Guillain-Barre, but it makes you worry a lot about HIV seroconversion, makes you worry a little bit about Lyme as an imitator, and it makes you worry about the main differential diagnosis to the experienced clinician of Guillain-Barre, which in my own personal experience has been an acute necrotic myelopathy or an epidural spinal abscess, which causes spinal shock and acute areflexic paralysis. Let me finish on the EMG without going into details. I get asked questions a lot, like, can you have Guillain-Barre with an entirely normal electrophysiologic study? And many of my colleagues say yes. I'm very dubious that that's true. It has to do with how much or how deeply you're willing to look, by which I mean, if you do late responses and you test a lot of nerves and you do proximal stimulation and you do blink reflexes, which by the way are underutilized, you will usually find an abnormality in one or another of those studies. If you do a casual study, which we're forced to do because of time limitations, and you do a couple of distal latencies and some nerve conduction velocities and needle a few muscles, and you don't find anything in a weak patient, I would say, well, then why are they weak? You're still looking for an explanation. Either it's not peripheral neuropathy, or you haven't done an extensive enough exam. And again, I mean, it's real life. You don't always have enough time. But I would submit to you that it shouldn't be possible to have weakness, for example, from Guillain-Barre and not find some electrophysiologic abnormality in a nerve referable to a weak muscle. But you have to dig. Okay, so that's on my sort of little diatribe on the CSF and the testing. There are other features in Guillain-Barre which are unsung, unexplained, and very tough to understand. And one of them is pain. Pain is very underappreciated in Guillain-Barre. It comes in several varieties. There are a few patients who seem to have small fiber trouble in addition to large fiber. We could talk about whether, the perineuritis that Asbury and Arneson described, which is a painful distal condition, is a Guillain-Barre variant. I really don't know because there's not adequate pathology. But I would say pain is not uncommon. However, the most common is a deep aching pain in the muscles early on, buttocks, hamstrings, quadriceps, low back, quadratus lumboris. Pain can be quite severe, and you get a couple of patients who kick around on orthopedic wards for a while with, being called lumbar stenosis and so on before they become weak. Very common, and I've been burned on that. There are other unusual pains, another which I called le coup du poignard, strike of the dagger. Guillain Barre starting with interscapular pain, which really should be a myelopathy, and then turns out to be peripheral neuropathy. I don't fully understand it. There's nothing about having pain in Guillain Barre that's informative about the illness otherwise. It's not more severe. It's not more rapidly progressive. It doesn't have a worse prognosis, I don't think. It's just something interesting that can throw you off, even as an experienced clinician. Let me do one share screen because I think it's informative in regard to the entire business of how how Guillain Barre works and why it's so heterogeneous. Okay, I think you can see this. This is from the famous Asbury, Arneson, and Adams, really iconic paper of autopsy material from Guillain Barre, which was a convenience sample and was conditioned by their ideas that were generated by an extraordinary man named Byron Waxman, who was sort of one of the first neuroimmunologists interested in T cells. This is their schematic depiction going from left to right of what Guillain Barre is. Can you all see this, Tracy?
Yes, we can see it.
Oh, thank you. Okay. So on the left, the idea here, and again, keep in mind that they started with a preconceived notion that Guillain Barre was a cell-bound lymphocytic demyelination. So you've got lymphocytes diapodecing, as it were, out of the blood vessel that's adjacent to a myelinated fiber. In the second picture part of the cartoon, the lymphocytes are now sensitized in some way to one epitope on myelin. And this was Byron Waxman's idea from his experimental autoimmune neuritis experiments. And they eat this up. They eat up the myelin. They cause segmental demyelination. The myelin dissolves. And you then have a denuded axon. And if it gets severe enough on the right, then the axon is damaged. How exactly, no one could say. Now, let me show you some actual pathology rather than theoretical. Here's a slide. I did about 25 to 30 autopsies on patients with Guillain Barre over the years, including a couple of Fissure Syndrome cases. This is a montage actually from two patients. On the upper left, you're seeing the typical, what I would call Occidental form, Western form of inflammatory demyelinating Guillain Barre. It's a Luxol fast hematoxylin slide longitudinally of the sciatic nerve, or a fascicle of the sciatic nerve. And you see a bunch of lymphocytes lined up linearly on the left there across the slide around a blood vessel, which if you look carefully, you can see in the middle of this or adjacent to it. And this, if you look at the upper right in cross section, you see that around vessels are these cylinders of lymphocytic infiltrates. You see a high power in the lower left, which shows several of these, but one in particular sort of just off the middle. And on the right is another example with a PTAH stain, which shows you this is within a fiber. So this is a vessel within a fiber, a nerve fiber, that is demyelinated. And you can tell that because the tungsten part isn't showing there, and what you're seeing only are the cells. So this, and here, moreover, in the middle is an EM, which shows the pathobiology of it. What you're seeing there is you've got an axon in the middle, you've got the myelin dark lamellae around it, and if you see where the arrows are, there's a macrophage there which has been attracted to the region that is lifting up the outer lamella of the myelin sheath and ultimately will insinuate its cytoplasm under that sheath and unroll it, almost like pulling off, toilet paper, until you're left with a denuded axon. So this is what one might call the archetype of this. And in pathology series that are relatively agnostic but can't be entirely, this accounts for about 70 to 80% of cases. However, there is a inflammatory type. This is actually backwards. There is a demyelinating type that's not inflammatory. And this is an example of it. This is a patient who got TPA and, as by the way, happened with streptokinase for unexplained reasons. A week to 10 days later gets Guillain Barre, and he died of pulmonary embolus. And he had intense demyelination, but the only inflammatory infiltrate I could find was in a proximal lumbar root in the bottom left. So the label of this slide is wrong. It's demyelinating, but Passi or non-inflammatory. That's Guillain Barre. He looked clinically like Guillain Barre. He had conduction block. He had prolonged distal latencies. He had high CSF protein. He died relatively early, but there was no inflammation. Then there's the axonal variant, and that really is the question. Should this be thrown in with Guillain Barre? Here's a silver stain on the top, which shows the axons. And what you're looking at is axonal torpedoes, meaning these swellings that show that the axons have been sectioned. And the myelin, of course, is damaged, but it's the axons primarily that look like they are the problem here. You see that also in the lower right, where there's a relative preservation of myelin shown by the blue Luxol. There's inflammation, but this is an axonal case. Now, there's a clinical axonal type. You're familiar with it. It's explosive, it's rapid, it's dazed, it's predominantly motor, it has respiratory failure, and it can include autonomic dysfunction. The CSF protein tends to be normal. The early EMG is reasonably normal until you hunt around with a needle and you find a lot of fibrillation potentials, and then that becomes fasciculations down the line, with very little in the way of conduction block, but very low compound muscle action potentials, and very little, if any, sensory potential abnormality, although there tend to be some. So the axonal variant is both a clinical entity that looks somewhat different from the typical inflammatory demyelinating type, and it's a pathologic entity. The two usually coincide. The problem being that in severe demyelinating inflammatory disease, the axons are damaged. And after a week, you get a lot of axonal damage, and it's hard to know what the elemental problem is. So I'm going to stop sharing and come back. Thank you. So that's sort of the scope of Guillain Barre syndrome. Now, the differential diagnosis I mentioned, it's not as broad as one would think unless you begin to believe that the trigger is somehow unique. So there's some interesting things that are worth knowing. The first is that in several large surveys, I would call them studies, obviously not trials, that have been done, say, in emergency rooms of people coming in with Guillain Barre who are queried about whether they had an infectious illness, febrile illness, in the previous 5, 7, 10, or 21 days, the rates of that recollection are identical to people who come in with hip fractures. And the skeptics have said Guillain Barre is not a post-infectious disorder. Well, I mean, it's easy to twist those numbers. I think that's highly dubious. We know a lot about post-vaccinal Guillain Barre, in which you know the day on which the antigenic challenge was made, and 7 days later, there are cases of Guillain Barre, maybe out to 21. So there's an instance where at least an antigenic challenge has produced it. We know a lot about the epidemiology of Campylobacter and particular serotypes. There are these Leor serotypes that are associated with Guillain-Barré, quite often an axonal variant, in daycare centers as triggers. And you get a bunch of kids who come down with Guillain-Barré as a result of having been exposed to what looks like a neuridogenic antigen. Zika may be a neuridogenic antigen. Probably it is epidemiologically. In the case of Campylobacter, the circumstantial evidence is very strong, and Mike Wilson can correct me on this, but there are epitopes on the surface of Campylobacter that simulate certain gangliosides in myelin, making it very plausible that it's a trigger and that the body produces autoantibodies and that the myelin or the axon is then an innocent bystander. And then there are other organisms that seem to precede Guillain-Barré more irregularly and have uncertain relationship, except for the fact that they are acute infections, either viral or bacterial, and usually febrile. There are interesting quirks there. Haemophilus influenza, while it is a very, very infrequent predecessor to Guillain-Barré, seems to have a propensity to be followed by Fissure Syndrome. People have been perplexed about that forever, and on and on. And then there is this quibble about Lyme disease. Okay, so in the Ardennes area in France, there are clearly instances of what has to be called Guillain-Barré after being infected with that Borrelia, which, as you know, is different from what we see in the United States. I know people on this Zoom call are, from all over the world. I have yet to be shown, with one exception, a case of American Lyme, US Lyme, that was followed by Guillain-Barré. There is a polyneuropathy that is delayed after Lyme, without a doubt, usually by weeks or more. It bears no resemblance to Guillain-Barré. It's much closer to, say, a snapshot of diabetic neuropathy. And I could tell you a longer story about that one case, but because I stood up on a soapbox and said never, and then it turned out to be so, which is a good lesson too. So I would say in Europe, maybe, but very rare, and it comes in clusters. Why? I don't know. There probably are other organisms that have a higher than expected subsequent incidence of Guillain-Barré, but overall their incidence is so low as an infection and as an underlying cause. It must be said, though, that there are a large proportion of Guillain-Barré cases in which no preceding trigger can be found. And that begs the question of, is this a cross-reactivity disease, or is it something completely different? Now, people with lupus can get some, and Sjogren's, aside from the more characteristic polyneuropathies that are associated with them, can get something that looks a little bit like Guillain-Barré, and it's appealing to include them in the S for syndrome. But I really don't know what to do with them. Now, I know it's, and HIV, of course, HIV seroconversion, especially in the early days of HIV when it was almost endemic in certain cities, there was an uptick in Guillain-Barré, and it looks just like typical Guillain-Barré. I mentioned the fact that many of those patients, as they seroconvert, almost like they would be seroconverting from any other virus, have cells in their spinal fluid. Most people don't with other viruses, as a signature feature. And they have odd aspects like pain, facial, Bell's palsy, and so on. So it's possible to speak about treatment at length. You're all familiar with the conventional treatments. The convenience of intravenous immunoglobulin has largely replaced plasma exchange. Now, I'll tell you why that's interesting. It's interesting to me because it unraveled, worked backwards, the origin of Guillain-Barré as a ICU disease for me. So at one time, just being lucky enough to be sitting in an intensive care unit that had a plasma exchange machine, you saw a ton of Guillain-Barré. As intravenous immunoglobulin was rolled out, more easily available, not always, and its ease of administration, just check a box and give IVIG, at whatever your dose is, patients stopped going to centers that took care of a lot of Guillain Barre syndromes. And several British researchers did a very interesting little epidemiologic observation. Richard Hughes, who's really one of the most authoritative people on Guillain Barre, from Guy's Hospital, which has since closed as a hospital in London, and found that in the United Kingdom, there was a doubling of mortality of Guillain Barre when these patients were not transferred to a center with nurses and respiratory people who were familiar with this type of respiratory failure. And he attributed that to the IVIG keeping people in the community. Now, that is not a criticism of capable people taking care of Guillain Barre where they stand. You don't have to transfer someone in. But in reference to the current epidemic of the SARS-CoV-2, I'm going to make the following observation. Neuromuscular respiratory failure is currently a rarity. When polio was rampant, it was the origin of respiratory and intensive care units in many countries. Ventilating somebody who has neuromuscular respiratory failure, of which Guillain Barre is the archetype, has no similarities to ventilating somebody who has parenchymal pulmonary disease. And the reason is that when you're paralyzed and your diaphragm and intercostal and other accessory muscles are paralyzed, your thoracic cage is like a bellows. There's no resistance. And people try to resort to low tidal volume ventilation for those patients, and they get screwed because you get a lot of atelectasis, shunting, hypoxia, and pneumonia. So there's a special twist to taking care of these patients, particularly once they require ventilation. And the majority of pulmonary critical care, anesthesia critical care, is about the stiff lung, an ARDS type. The two are completely different. And the ventilator settings, peak pressures, everything, volumes, what you're looking for, what you examine the patient for, what you're looking at the chest x-ray for, are completely different. And I'm concerned about that. Again, what's going on now is far more ubiquitous and far more important, but it's a comment worth making. The other thing is that I have not had time to talk about the dysautonomia, which is a very interesting feature. And that's one of the reasons that pure pan dysautonomia, particularly when it's post-infectious, is considered by a lot of people to be a GBS variant as well, but it's an entirely different subject. So I'm actually going to end there and mute myself, and I'm going to let Dr. Milligan moderate questions. But I want to thank you again for listening. I hope that's been interesting. I wanted to start in the middle of the story because I know that virtually everyone in this call knows what Guillain Barre syndrome is. So I didn't want to give a sort of elemental lecture, but I'm very appreciative. And I would endorse what Dr. Milligan said. You should all read my most recent book, How the Brain Lost Its Mind, which is about, believe it or not, syphilis and neurosyphilis and our current understanding of the relationship between the brain and insanity. Thank you very much for your attention. Thank you for allowing me to plug the book. I'm going to mute myself now.
Thank you very much, Dr. Ropper. So Dr. Ropper will take questions now. If you would like to put your questions in the chat box, we'll take questions from the chat box. So I think we already have one. And let's see, if you ask your question to everyone, then Dr. Ropper will definitely see it. The first question, though, was a private question to me. So let me read that to Dr. Ropper. And that question is there a difference in the clinical presentation and prognosis of patients with Florid inflammatory versus Passi inflammatory GBS histopathology?
Well, we don't know because almost all the histopathology and all but one case in the Asbury-Arneson series, which has good clinical material, are people who died. Now, many of them died of PEs and MIs. So we don't know what the milder end looks like. However, there is a broad correspondence between the severity of weakness, the component that's due to axonal damage, and the electrophysiologic studies. And there I would say it's highly likely that the more axonal damage you have, the more severe the illness and the more protracted the recovery, and the more likely it is that you won't get full recovery. So I think that what travels with prognosis is the degree of axonal damage. Let me take off on that comment for a moment. It's a great question. I get a lot of phone calls from clinicians saying, I have a patient here and I treated them with the 5-day course of IVIG and they're not getting better. What should I do? What they're really asking is, should I give another round of IVIG or should I switch to plasma exchange? And my first question to them is there axonal damage? Because if there is and the patient's not getting better, you can do what you want, but they're not going to get better. That's another way of answering that question. But with regard to the pathology, I don't think it's possible to make a categorical correspondence. But thank you for the question.
And we have a number of other questions. Dr. Ropper, if you're able to access the chat box, I think you'll be able to take them from there. And we just, you'll have to unmute yourself. While you're accessing it, I'll read off the next question from Dr. Akbik, who thanks you for doing this and says, would you mind commenting more on the observed dysautonomia?
Right, the dysautonomia is really fascinating. It's likely, from work that I and others have done, Ilko Vedics, it's likely due to de-afferentation, it's the wrong word, of the aortic arch mainly, which just lets the baroreceptors centrally run free. And so the typical case would be extreme hypertension and extreme hypotension that alternate and are very difficult to control, along with a fascinating phenomenon of invariant heart rate. That is, I have some slides, but it would take too long to pull them up. So that if you do a trend monitor of the blood pressure, you'll see it go up and down and up and down and up and down, and sometimes people becoming syncopizing, even supine, with systolics of 50 or 40, and then having blood pressure systolic of 210 20 minutes later. But if you do the trend monitor, you look at the heart rate, stays completely constant. And that is because one of the earliest features of Guillain Barre is that patients are vagotomized, probably on the basis of an inflammatory infiltrate in the vagus. And of course, the vagal nerves also set the set point for the aortic and other baroreceptors. It's very difficult to treat. The bigger mistake is to chase the hypertension too aggressively and then have to dig yourself out of the trough of hypotension. So I let the blood pressure ride up, or I have in the past, a little bit more liberally than most people in order not to have to give pressors 20 minutes later. That feature, by the way, of invariant heart rate, a lack of RR interval variability, is an early feature of many, many patients with Guillain Barre. And you can make the diagnosis by just taking the radial pulse, asking the patient to breathe deeply, and notice that there's no respiratory sinus arrhythmia, which is a phenomenon, of course, effectuated by the vagus. And a lot of people have that, even without getting blood pressure dysautonomia. Furthermore, there are a small proportion of patients with typical Guillain Barre who have urinary retention at the beginning of their illness as a dysautonomic feature. And that throws everybody off because they go, well, it's a peripheral disorder. How could it be? And well, it is. There are a few patients who get pupillary unreactivity, generally first to accommodation before unreactive to light, without having an ophthalmoparasis. Very interesting. And a lot of patients with a predominant dysautonomia will also have that. Dermatographia and the axon reflex goes away in early Guillain-Barre, and it's gone. You can just run your fingernail along their back, along the spine. Almost everybody, after 4 to 5 seconds, will raise a little bit of a flare as an axon reflex along where you scraped your finger. And many of them will also get a wheal from histamine release locally. But patients with Guillain-Barre and dysautonomia lack that. And just like the invariant heart rate, a lot of patients with conventional, typical Guillain-Barre will also have that sign or the lack of that sign. Does that answer your question?
That's great. Thank you. So are you able to access the other
I'm
questions?
not. I'm seeing
Okay.
participants and I can't
All right.
see the chat.
That's fine. I'll go on to the next question. Association of GBS with COVID-19.
Yes. So now you're aware that the New England Journal, I think it's out, published a sort of a research letter on these cases. I've seen, I'm not exaggerating now, forgive me, at least 30 other small series of Guillain-Barre a week or to 2 after the onset of COVID. I'm not impressed in the sense that I think it's just another virus. Now, if you want to hear something interesting, there were Guillain-Barre cases after the 1918 flu epidemic, but there were a ton of Guillain-Barre cases in New Orleans in the 1880s after yellow fever. So almost any organism can precipitate this, and it's going to allow me to make another interesting observation. So I don't know if there's anything special about COVID, whether it is neuritogenic would be the best word I could choose for it. I'm not sure there's something special about it. Zika was studied carefully enough epidemiologically to suggest that there probably was a propensity. But I would ask this question somewhat rhetorically. I worked at St. Elizabeth's Hospital for 14 years, a small Catholic hospital in a neighborhood of Brighton. Across the street was the Franciscan Children's Hospital, Rehabilitation Hospital. And in about 1986, there was a little endemic in that children's hospital of Campylobacter. And about 80, 90 kids got terrible Campylobacter diarrhea. It's about 300, 400 bed hospital. Very interesting place, but that's a separate story. So you get about 80 kids with documented Campylobacter. Public health authorities are in there, and so on and so forth. 9 got Guillain-Barre. Why did the 71 others not get Guillain-Barre? This speaks to an essential question about the immunopathology, I would say, or immunopathophysicology. There's something special about the host that makes Guillain-Barre happen as much as about the organism. Now, if for COVID, somebody did some kind of deep sequencing of a lot of epitopes and looked at HLA and so on, which, by the way, there's never been a consistent HLA haplotype representation in Guillain-Barre as a whole, but no one's really looked for particular organisms except for Campylobacter. There's something special about the host. But the answer to your COVID question is, I'm not sure, but I think there's just a lot of COVID. It's very acute, and they're just like every other organism, it's going to be followed by some cases of Guillain-Barre. And you could say the same thing about vaccines.
Thank you. Next question. Another thanks for the amazing lecture. What is your opinion on treating acute pan dysautonomia with IV steroids versus IVIG?
Okay, so I avoided completely mentioning steroids. Before plasma exchange came along, and I'm going to deny this. I know it's being recorded, but I'm going to deny saying it. We used to see Guillain Barre patients rapidly declining, standing there in the middle of the night with a tube and a laryngoscope, waiting to decide whether or not we should intubate them. And as their vital capacity went down from 1.5 liters to 1.2 liters to 900 mLs, and you were on the brink, we used to give those patients 500 milligrams of methylprednisolone. And I assure you that a lot of them turned around in hours like that. Vital capacity went up, shoulders started to move. So why don't we use corticosteroids? Well, we don't use corticosteroids because of one randomized trial, one in the Lancet by Richard Hughes that had 11 patients, one of whom committed suicide, which tipped the scales in favor of not using steroids. And since then, we have not used steroids. I still treat pan dysautonomia, or suggest it be treated with IVIG because it's conventional. There has been a decent trial of adding steroids to IVIG, which showed no incremental benefit, but there was no arm of steroids alone because the investigators in Germany, mainly in Cologne, felt that there was no equipoise. So the party line, the authorities in the field say no steroids. I would love to see that tested again. Now, of course, you pay a price, right? Gastric erosion, hypertension, hyperglycemia, and susceptible people. But there haven't been enough studies or trials of pan dysautonomia to have a categorical answer to the question of what's the best treatment. However, it's fair to say that the conventional answer is IVIG.
Oh, thank you. Another question. Have you seen patients with central involvement with fluctuating levels of arousal for no clear associated metabolic toxic infectious cause? And also, thanks for the great talk.
Yes, thank you for the question. Again, this is almost another lecture, and it blends into Fissure Syndrome because, as you know, Bickerstaff and his colleague Allan have been writing about Fissure Syndrome as a central disorder for a very long time. I'm very dubious. I don't have time to go into why, and I've taken this position largely to keep the conversation alive. I have seen patients, rarely, who are drowsy, and I don't know why. And you could propose that they have central inflammation. In large autopsy series, there is absolutely no doubt that you find a few foci, especially in the spinal cord, of perivenular inflammatory disease in the spinal cord, and occasionally in the brainstem or brain. I don't think they're enough to explain reticular activating system dysfunction. So I don't understand those cases. I think they're very, very rare. I've seen a lot of cases of oneric states, meaning dreamlike states, in which patients seem to have a dissociative reaction. And when they improve, they will tell you the incredible experiences that they had during those states in which they remember being unable to respond. I don't know what that is. One of my patients swore that he got married in the intensive care unit to a woman he did not want to marry. That was his dreamlike state. And he thought I was complicit in forcing him to get married. And it was very vivid to him. During those states, those patients are essentially look unresponsive with the lids half open. I don't understand that.
Thank you. There's another question that is, maybe you can expand more on your earlier comments. So is it worthy to repeat a 5-day dose of IVIG in cases of failure of treatment? And how about plasmapheresis, clean out IVIG administered previously? And I think this is a question that you must have heard quite often, is after IVIG, what next?
Well, there are going to be 2 trials that suggest that a second treatment with IVIG is not effective. The reasons for that are manifold. The first is, why would it be effective if it wasn't effective the first time? The second is, you're now 2 weeks into it when treatment really doesn't make a difference. However, the patient's doing poorly. They may or may not have an axonal variant. And there's pressure from the family, from the patient, even internal pressure to do something. So I don't object to it, but I really don't think it's effective. The idea that plasma exchange would wash out, as it were, the IVIG, by the time you get around to doing the plasma exchange, you're not really looking at much residual IVIG in the circulation. You're looking at antigen-antibody complexes that can be measured using Raji cell assays. And you do wash them out, but they're probably irrelevant. So I don't know that it makes a lot of sense. Now, there has been a legitimate, published, randomized 3-arm trial looking at plasma exchange first, followed by IVIG in patients who fail. And although the trial was not large, it didn't show any beneficial effect. So we have very little evidence that sequential treatment in either direction, exchange first, IVIG second, IVIG first, exchange second, 2 IVIGs, 2 plasma exchange courses makes a difference. And there are probably good reasons. Everybody does it, but it's not well founded. You could say that the absence of evidence is not evidence of absence of effect. Trials are small, so I don't think it's a closed question, but it's probably worthwhile going into that with a realistic expectation you're not going to do much. Let me say the following also. When the North American plasma exchange trial was finished, there were 14 centers that participated. Guy McCann got everyone together in a hotel in the suburb of Baltimore. Now, this is a blinded trial, so the assessors did not know who got plasma exchange and who did not get plasma exchange, okay? The blinded assessment of this randomized trial. And he asked all 14 principal investigators and assessors to write on a piece of paper whether they thought plasma exchange was effective, okay? 13 of 14 said no, it was not effective by their observation. And yet, statistically, it was very effective. The reason I bring that out is that when you say, I treated the patient and it worked, or it didn't work, you don't know what you're talking about, because these trials demonstrated a shift in median time to improvement. But in any individual patient, because of the variability of the disorder, you can't tell who's getting better and who's getting worse. So you may have treated somebody and you may have made them ultimately get better 50% faster, but you can't tell on day 6. So the expectation that treatment would lead to improvement that you can visibly perceive at the bedside is erroneous. It's a statistical improvement. So even when you ask the question, you got to wonder, what am I asking? You probably have done some good if it's a demyelinating variant, but you don't like the rate at which they're getting better. Well, that's the variability of the disorder. We need something better that shuts it down, probably an anti-complement.
So we have a number of other questions. I'm not sure we'll be able to get to all of them, but here's the next one. Have progressive dysautonomic manifestations been found after the acute phase, or is it only part of the acute phase?
It's generally part of the acute phase, but it can carry on for weeks. And then there's the deconditioning problem. I've never seen it appear late, but it can persist. I've had patients in the ICU, we published a few of them, who have dysautonomia for 2 and 3 weeks, and then it tails off. And afterwards, I have to say, I didn't follow them carefully, so I don't know if they still have orthostatic hypotension. They could. But these are small, thinly myelinated fibers, and they probably recover to some extent.
And how common in your experience is it to leave a patient without intervention in the demyelinating type? Are there patients that you don't treat?
Yeah, okay, so all the trials required Hughes or MRC grade 3, meaning that patients were unable to walk 5 meters without assistance. That is, all the trials, except for one French trial, only included patients who can no longer walk. So you could ask a good question. If somebody comes in and
So unfortunately, we seem to have lost audio, and we're running short of time. We're at our mark now. So please accept my applause on behalf of our entire audience, Dr. Ropper. Thank you so much. And we'll see if we can address some of the other questions through my Twitter account at Tracy1Milligan. Have a wonderful afternoon, everybody.